the University of Tennessee. Welcome to our colloquium program. Today we're lucky to have Dr. Jason Davis. He's a health physicist with the Radiation Emergency Assistance Center training site, REAC's, medical team at the Oak Ridge Institute for Science and Education. He's responsible for responding to calls for radiation emergency assistance, performing internal-external radiation dose assessments as part of medical response, development and delivery of REAC's continuing medical education materials, and assisting with health physics integration of the REAC's cytogenic biodosimetry laboratory into radiation incident response. He has more than 17 years of experience in radiation protection, diagnostic medical physics, emergency response, internal dosimetry. His primary focus at REAC is the integration of health physics into the medical management of radiation events. Prior to REAC, Dr. Davis's experience included reconstruction of doses for former radiation workers, radiological engineering and dosimetry oversight, and quality assurance and patient protection in diagnostics and therapeutic applications of radiation. He's certified in the comprehensive practice of health physics by the American Board of Health Physics. He received a Master of Science in Health Physics from the University of Nevada, Las Vegas in 2008. He was awarded his doctorate in Applied Physics by Idaho State University in 2014. Welcome, Dr. Davis.
Thank you. Actually sounds very impressive when it's coming out of your mouth, Dr. Hines. I'll have to have you act as my MC from now on whenever I'm presenting.
More than happy to.
So thank you for the introduction. As Dr. Hines said, my name is Jason Davis. I'm actually one of two full-time health physicists at REAC. We do have a couple of contract health physicists that will provide assistance if we need, particularly if we're ever deployed for an offsite emergency or things like that. For any of you that are not familiar with REAC, we are in the basement of Methodist Medical Center in Oak Ridge. We're a very small group, but we provide on-site and off-site assistance anytime there is a radiological incident or emergency that requires any kind of medical care. Anything from skin contamination to medical overexposures to some of the big type of events that we really don't like to talk about all that often. So I've been asked to present a little bit of information to you today, and specifically I'm going to talk about an area of my current research, which is some of the challenges associated with assigning dose to a radiologically contaminated wound. I have to start off with the standard disclaimers. I'm not a physician, so none of what I say should be construed as medical advice. I don't get to provide medical advice or diagnoses. Instead, I get to advise physicians and allow them to provide that medical advice. That way I don't have to carry any kind of malpractice insurance. Second disclaimer is that this presentation is not going to be covering the biokinetic models in NCRP report number 156. I do lecture on that as part of my duties at REAC, but I won't actually be specifically covering that in this lecture. I will actually make some reference to it, but it's not going to be the overall focus of this lecture. Now, unfortunately, accidents happen whether you're talking about in an industrial setting or a medical setting, at Department of Energy laboratories and nuclear power plants. Accidents can and do happen, and it is possible for people to end up with radioactive materials in a wound or a wound caused by radioactive materials. These events are rare. And because of that, there's not a lot of expertise in how to handle these sorts of emergencies or these sorts of wounds. And the types of approaches we would take ordinarily to assigning dose, things like dose averaging and assumptions about the thickness of skin, they work great for record keeping and for assigning an individual's dose of record, but really don't work well as far as providing advice to the medical practitioners on what types of symptoms we should see develop or what types of treatment may be warranted. And the guidance on the issue is very, very limited. Going back to that NCRP report, in the entire volume, there are maybe 2 pages devoted to how to actually assign a dose to the wound itself rather than to the entire body. So the treatment team will need some very specific information from the health physics or the radiation protection personnel. Specifically, they're going to need information in terms of what type of dose the patient or victim may expect. Usually, we assign an absorbed dose based on some simplifying assumptions. We usually assume that the tissue of interest, the basal layer of cells, is about 70 microns beneath the surface of the skin. And from a regulatory standpoint, we also typically assume a point source or a distributed energy source sitting right up on top of the skin. We can use those factors or those assumptions to average a dose across 1 centimeter squared of basal skin tissue. Why do we specifically look at the basal layer of skin? Well, because that's the actively dividing layer of skin. That's where the cells are proliferating. That's where all of our skin cells that we can see actually start off is down in that basal layer before they evolve and migrate out into the outer layers of skin. So we can use those assumptions and get a rough approximation of what an individual's dose would be, again, from a regulatory standpoint. We can use that even to figure out if we need to do a survey of an individual, if we have, say, an alpha scintillator. The one I use in my practice is the Ludlum 43.5. I'm not advocating for that detector in any way, shape, or form. It's just the one I was trained on. It has an efficiency of about 12.5%. So I can figure out roughly how much material is in the skin based on the number of counts I'm getting from that alpha scintillator. Again, assuming a deposition right up on the skin. So I could take that measurement, figure out the energy deposited in that 1 square centimeter, divide it by some mass, and get a dose. It seems pretty straightforward, right? Well, not always. Whenever I'm teaching my classes at REACs, I like to emphasize that in all cases of dosimetry, there is always a but. And sometimes it's a very large but. And in this case, it's an insanely large but. When it comes to a contaminated wound, we can't rely on our usual assumptions. Usually we assume that alpha emitters aren't an issue because the majority of the energy is going to be absorbed in that dead layer of epithelials on the outside of the skin. We kind of make the same assumption for low energy beta emitters. We can't make the same assumption for the depth of skin because the skin's depth actually changes not only across our body, but also as we age, it starts to vary. The skin thickness will start to change. If we're talking about a contaminated wound, we also can't make the usual assumption of an instantaneous delivery because the material is physically in the wound, it's decaying over time, it's going to be a protracted dose. So first, let's talk a little bit about wounds and how different materials will impact wounds. Usually the skin is very, very good at its job, which is protecting all of the soft, squishy stuff inside our body. It's very good at keeping foreign materials out and keeping all of our moisture and electrolytes in. If we break that barrier, then it can cause issues as far as keeping some of the material out. And the type of wound can actually have a very large impact on how effective that skin barrier is. And the current models we have as far as how material can be absorbed deeper into the body doesn't take into account the difference between the different wound types. So just to give you a warning, there are some clinical images coming up. So if you have a squeamish stomach or are put off at all by the sight of blood or anything like that, go ahead and close your eyes now, and I'll let you know when it's safe to look again. So the first type of wound to consider is an abrasion. This is where the integument, the outside layer of skin, is actually compromised, uh, but not to a very deep degree. Usually there's very little bleeding. That bleeding that's there is usually caused by the rupture of small veins and capillaries, but the wound typically doesn't make it down to the deeper layer of tissues. In these abrasions is where you would see things like accidental tattooing. So I'm a motorcycle rider. I've been in motorcycle accidents and had other people with me in motorcycle accidents and seen where they'll get asphalt, dirt, and things like that in the abrasion. And the material tends to be retained very, very strongly in that abrasion because the wound isn't deep enough to allow for macrophages to come and clean that material out. So depending on the size and makeup of the material, that material can actually stay there for years up to decades. That's actually kind of how tattooing works. Next is avulsions. This is where the skin is forcibly torn from the body. Usually we see very intense bleeding that occurs immediately. It's not the slow weeping that you see with just a superficial scrape. Incisions are very, very clean wounds. They have smooth sides, usually caused by something sharp like glass or things like that. They can bleed very, very severely, but they also heal very cleanly. Lacerations are ones that are more jagged, and lacerations are the ones we actually kind of expect to see in an accident situation in industry. They're irregular. Typically, they're contaminated with soil and debris and things like that, and they can also bleed pretty profusely. And finally, puncture wounds. This is where you see very, very deep damage and probably not a lot of blood, but there's a large potential for infection. And if there is material deposited in a puncture wound, it can be very difficult to see to begin with, and even more difficult to treat without invasive treatments like surgeries and things that go beyond a regular emergency room debridement. Now, in general, when it comes to any kind of wound, medical treatment is always going to come first. That's a point we emphasize all the time at REACT, that radioactive contamination, even in a wound, is a nuisance more than anything else. If somebody's bleeding, that bleed is much more of a risk to their life and safety than the amount of radioactive material that could potentially be in there. Now, the decision to treat a radioactively contaminated wound is very, very complex, and it's not one that a single individual can usually make. It usually takes some collaborative discussion between a surgeon, an anesthesiologist, maybe a toxicologist, and for radioactive materials, a health physicist, because we have to be willing and able to balance the concerns of the radioactive material and any type of local dose it may deliver, or whether the material will mobilize and actually become systemic, as well as any kind of foreign body reactions. We have to balance those against the potential for scarring. Those scars can be disfiguring, and they can also cause mobility issues depending on where the scars are. There's always a possibility of complications within any kind of surgery. And since most injuries in an industrial setting tend to happen to the hands, there's some very delicate, very sensitive structures that have to be avoided. Typically, an individual that has a contaminated wound on their hand will not be able to be treated in a standard doctor's office or in an emergency department. Generally speaking, it's necessary to bring in a hand surgeon, a specialist that knows how to avoid damaging any of the tendons, muscles, and neural pathways within the hand. So, from our perspective as radiation professionals, we have to be able to provide some kind of information to the medical team that's going to help them make the decision on whether to operate and if to operate. It helps if we could tell them the isotope, which the best way to get some information about the isotope is actually to talk to the patient, figure out what they were working with. It helps if we can tell them how much material is there in the wound. And crucially, for purposes of planning any kind of treatment, we have to be able to tell them very, very precisely the location of the material within the wound. Because when it comes to some of the nerves and vascular pathways within the hand, especially, uh, being off by a millimeter can mean the difference between an individual successfully recovering and being permanently disabled. Now, if you've had the radiation detection class, I'm sure you've seen this formula, at least in passing, reading Glenn Knoll's book. Glenn Knoll tells us how we can figure out the activity at some distance away from a radiation detector. The activity is incorporated in that S. The S is actually the activity times the yield. As long as we know the size of our detector and the efficiency of our detector and the depth or distance of the contaminant, we can figure out the activity fairly easily. The math isn't too bad. Unfortunately, having something like this where you're talking about a source of radioactive material that you can't visualize very easily can introduce a lot of uncertainty into your measurements. And very, very small changes in that distance between the detector head and the source of radioactive material can have large impacts on the efficiency of the detector, which in turn will have very large impacts on what we calculate as the activity in the wound. So very small errors can add up quickly, uh, at least in terms of a radioactively contaminated wound. We also need to know the distance with some precision because, again, now we're talking about material that's physically embedded down in the tissue. Usually we think about the skin as multiple layers between 500 and 100 microns thick. And we tend to think about the radioactive material having a limited range, well, at least the radiation having a limited range. That's where we get our rule of thumb that alpha particles really aren't an issue, because taking thorium-232, for example, a 4 MeV alpha particle, it's got a range of about 25 microns in human tissue. So it's not going to make it past the dead layer of skin on the outside, and certainly won't make it as far as the actively dividing cells. But as we increase the energy, going up to radium-223 with a 5.7 MeV alpha particle, well, now we're getting up to a 43, almost 44 micron range in tissue. Still probably won't make it down to the active dividing layer of cells, but that's enough energy being deposited in some of the granular cells and things like that, that it can cause blistering and start to degrade the protective barrier of the skin. And things start to get even worse once that radioactive material is down in the skin, because now we don't have the protective shielding of the dead layer of epithelials. The material is farther down, so that 25 micron range now might be able to make it to the basal layer of cells. And the 43 micron range most certainly can deliver some type of energy to that basal layer of cells. Remember also I mentioned that typically we assign a dose to a square centimeter of skin, which again is useful for record keeping, but maybe not so much for predicting biological effects of the radiation. Because each of the different alpha energies will have different track structures, they're going to irradiate different volumes of tissue. So we can't use that square centimeter assumption anymore. The amount of tissue there that we'll have to divide the energy by is going to depend very strongly on the energy of the alpha particle. If we're considering medical or biological effects, we also have to take into account that the basal layer of cells may not necessarily be the tissue that we need to worry about. When you get about 1.5 to 5 millimeters down into the skin, you start to get into a vascularized or an area with lots of superficial blood vessels. We typically don't think about superficial blood vessels or blood vessels really at all when it comes to radiation protection, but the vascular cells, the cells actually making up our arteries and veins, if they are damaged, they can start to become leaky. So not only can the serum and blood cells start to make it out of the vasculature, but other pathogens can make their way in. So we have to be cognizant of where these cells are, where these structures are in relation to our radioactive material. If enough of a dose is delivered to the vascular tissue, to these arteries and veins, it can actually cause the vessels to die off. They'll actually start to become necrotic and close themselves off to avoid any kind of bleeding. And that will cause the overlying tissue to actually kind of pull in on itself. It's a process known as induration, where you'll actually end up with a divot in the skin because the vascular cells aren't there providing nourishment for the cells up above anymore. So that's enough of the nasty medical stuff. Let's get back to dosimetry for a little bit. You know, we're engineers and scientists. We want to talk about the actual radiation. We want to talk about the energy being deposited. Well, we can't skip it just yet because we have to think about one more factor when it comes to dosimetry of a contaminated wound. Specifically for very local doses, like what we see with embedded radioactive material, we essentially get into a battle, a back and forth between the kinetics of radioactive decay and the kinetics of tissue regeneration. Because once our skin is damaged, it will attempt to rebuild itself. It typically does this from the bottom up. So the basal layer of cells will repopulate and then send newer cells out into the more outermost layers until the wound closes up. If we have radioactive material down there in the wound, those cells are going to be irradiated at the same time that they're trying to divide and at the same time that they're trying to repair this damage, this wound. So we have to think about the biologically effective dose. It's a relationship of the energy deposited to the surviving fraction of cells. In order to get this relationship, we have to take into account the radiosensitivity of the cells, as well as the time frame over which this dose is delivered. For any of you that are in the medical physics program, you might have heard some of this already as you're talking about things like brachytherapy or fractionated doses. You've already talked about some of the survival curves and the difference that the irradiation time or the fractionation schedule will make in that survival curve. With continuous protracted radiation, we have to take into account uh, the cell reproduction rate as well. So we have the cells that are trying to actively divide, and we have some damage being done to the cells. We also have energy being deposited that's causing sublethal damage that may cause some of the cells to be irregular or things like that. So we have to take all of those things into account, all of those individual kinetics into account the entire time that that radioactive material is inside the body until it either decays completely or is otherwise removed from the body. This process is going to continue. We have to take into account the dose rate effects on cells, which lumps in not only the radiosensitivity of the cells, not only the probability of delivering a certain amount of energy to the cells, but also the fact that juvenile cells, actively dividing cells, tend to be much, much more radiosensitive than mature cells that are already done dividing. Okay, so how much energy is being deposited by our radioactive material? It's another thing we need to consider because one of the questions we meaning I guess, will be asked by the physician is, if I leave this material in there, is it going to deliver enough of a dose to cause a deterministic effect? Or is it going to deliver enough of a dose to cause a stochastic effect? For the second question, the answer is always maybe. First question, okay, we can figure that out by looking at how much energy is being deposited over a certain distance. Remember that the track structures of an alpha particle is going to be very, very dependent on the energy of an alpha particle. So if we look at it in terms of the dimension of individual cells or individual tissues, we have to take into account the fact that some cells may be crossed by more alpha particles, whereas other cells may be crossed by fewer particles, but because of the way the alpha particles deposit their energy, because of that Bragg peak we see toward the end of the alpha particle's path, you might actually see more damage for a single transit than you would for a cell that's receiving multiple transits closer in. Dr. Hines, how am I doing on time? My clock has turned itself off.
Yeah, you have about 15 more minutes.
Okay. Ordinarily, I would stop right here because the next portion is actually a separate lecture, and because when I start to put lots of figures and equations up on the board, my medical students shut off mentally. But one other thing I would like everyone to consider, especially those that are going into medical physics, if you've got any interest at all in diagnostic medical physics, is the detectability of material within a wound. It's easy to think, well, if they've got something down in a wound, wouldn't we be able to see it with a radiograph or something like that? Well, unfortunately, that's not always the case because with plain radiographs, there's a limit to the resolution. I don't know if you can see the little itty bitty red circle there, but inside that red circle is actually a fragment of metal. So this is actually aluminum. Aluminum doesn't show up very well on radiographs. Neither do plastics, wood, thorns, and things like that. So we can't necessarily rely on radiography to tell us what or whether there is material there. In an ideal world, size wouldn't matter. There wouldn't be any kind of umbral or penumbral effects. The images would be sharp and everything in the body would be visible. We'd know where everything is. Unfortunately, that's not always the case. Because we have short exposure times and a spread projection, we have a lack of depth resolution. The problem can be even compounded farther when it comes to CT, because now we have volumetric considerations. We have to figure out how much of a voxel, a 3D pixel, is going to be occupied by that material in order for us to be able to see that that material is actually there. So I'll leave that as a, if you want to know more, please reach out and contact me, because again, this is an area of my current research where I'm trying to figure out how much material can be in a wound before we'll see it, how much material can be in a wound before it will cause different deterministic effects, and how can we minimize some of the uncertainties associated with localizing and quantifying the material within a wound. With that, thank you, and I will entertain any questions.
Yep. So feel free to raise your hand or just unmute. So Jason, I kind of have a question. Maybe you could, I think it's always interesting for people to see the theory and the process, the procedure and all that. But do you have any, quote, C stories where, something happened and you went out, keeping, of course, the privacy of medical records. But do you have a story maybe to share? I mean, how often would you go out in a year or in 5 years to assist with something like this? It seems like it'd be a very rare event.
Thankfully, it's rare that we go out for puncture wounds. Usually the types of situations we end up having to respond to end up being more like an inhalation. More than once in the last year, we've had instances where somebody is cleaning up a substance and the HEPA filter will actually become disconnected and they end up with a face full of radioactive materials. So we have to figure out the potential dose and if we need to do any kind of decorporation. But we actually did just recently deal with a puncture situation. An individual was placing marker flags in these little cans. They essentially looked like paint cans of radioactive material. And as they put the marker flag down into the can, the marker flag bent back up and actually went through the individual's leather work glove and into the web between their index finger and thumb. So this was a case where we had to call in a hand surgeon as a specialist because damaging the nerves in that web area could have potentially disabled this individual. And because we didn't have a detector with good enough resolution to detect the very, very low energy photons that were being emitted in the wound, what we had to opt for was a series of punch biopsies. So they essentially went in with what looks almost like a paper hole puncher, punch out a little bit of tissue, make a measurement of the tissue and of the wound, and then go back and do that over and over and over until we were reasonably sure that we had taken most of the material out of the body.
Wow. See, I find that as really interesting, and I think it's useful to hear those stories so that you know how quickly something like that can happen, and always makes us go back to, our number one goal is to be safe. Dr. Halbron, you have a question?
Yeah. Thanks, Jason. That was a very interesting talk. When you're looking at the survival curves that you had, looking at the biological effective dose, does that include cells that have damage but misrepair and survive as well? Are those included in the cell survival?
Yes, we actually take into account for the cell survival curves, we typically use a two-target model. So the primary target is going to be the densest part of the nucleus, and any transits across there, we assume that they're going to be lethal to the cell. Any areas on the periphery of the nucleus or in the cytoplasm, those will be non-lethal, but carry the potential to cause structural changes and morphological changes.
I see. So do they also include then different parameters for alpha and beta?
Yes, each one of the curves are different for each radiation type and different for each individual cell type. So the curves we use for skin don't look anything like the curves we would use for lung tissue and things like that.
Right. Yeah, thanks very much.
You're welcome.
Okay, Promise, I saw you had your hand up earlier. Do you still have a question?
Yeah, I think my question got answered in the question you asked. My question was, like typically how does like radiation get into people's wounds? Like how does that happen? But in what Dr. Davis mentioned, like with the punctures and all that, it made more sense.
Yeah, we've had some other cases that we've worked on recently. One, an individual knelt down to pick up a tool and didn't realize when they knelt down that there was contaminated, very, very small, but contaminated glass shards on the ground. They didn't realize that they had received a wound until the end of their shift when they went to change out of their work clothes into their home clothes and noticed very small little spots of blood on their clothes. So we have cases like that. We have probably my most unique case was an individual that was working in an airborne radioactivity area. Their PPE was compromised, their coveralls were compromised, and underneath their coveralls, they had a fresh tattoo. So that one was fun to try to estimate the dose.
Great. Do we have any other questions? Okay, well, let's thank Dr. Davis.
Thank you all.
And really appreciate you coming in and sharing a little bit about what you do and what ORISE REACS does. It's something I've seen, maybe a brochure or something in the past, but I've never had anybody really discuss it with me. So thank you, and everybody have a great day. Bye-bye.
You're welcome. Thank you. Bye.